and gentlemen, dear panelists. It is our honor today to be working together with Professor Wu and introduce Professor Wu in our cat lab. Dr. Hisham with me here who picked up this case, in fact, so he will present the case to you.
Our patient is a female, 81 years old.
Yeah.
She's having resistant hypertension, end-stage renal failure. She's on hemodialysis. She had also history of pleural TB, and she is maintained currently on anti-tuberculous medication. She had history of ischemic heart disease that goes back 9 years ago, where she had her first PCI to her LED with a bare metal stent. Unfortunately, we don't have report for that intervention. Currently, she presented with severe chest pain with a T-wave inversion in all her chest leads, associated with severe hypertension. Her clinical examinations were unremarkable except for this uncontrolled hypertension. Her echo showed mild segmental wall motion abnormality related to her LAD territory with preserved LV function, ejection fraction more than 50% with an evidence of LVH and calcified mitral annulus.
Yes. So we probably use a 2.5 has been used. We can pre-dilate the lesion, all the lesion. Yeah. Then and another wire in the circ, please. Okay, for the test. Right. Okay, here, up. Okay, 16. 16. All right, deflate. Okay, for the second lesion. All right, test. All right, here, up. Again, 16. 18. Okay, done. Okay. So test again. Okay, here again. Yeah, I think we need to cover all the segment. Okay, dilate. Okay, 16. Io quarter. 18. Yeah, continue. Go. 18. Right. Okay, done. Yeah. All right. Yeah, lemon. Okay, here. Okay, 18. 18. Okay, different. Oh, prepare the IVUS. Give some nitro. Let the patient. Yeah, take angio again. Yeah. It's been dilated with some residual stenosis. Yeah, because it's okay. But in this view, it seems like more disease. Yeah, left me. So we can check with IVUS. Yeah. We can dilate it more. Then we check with IVUS. Okay, again, 24. Because angioscope is short, we need multiple, inflation. 4. Okay, done. There's, okay, here. All right, up. 26. Okay, done. Let's move a little bit. All right. So before we do left main and LAD osteo and multiple tendon lesion in the LAD, because we do have diagnosis shot by Dr. Hisham, and they showing that RCA in the proximal and mid portion also have two borderline lesion. And this morning, as before with the live demonstration, I shot with Dr. Hisham again in the RCA and showing that the severity of the RCA stenosis is even worse. So in consideration, we are doing the left main already osteo, so we like to fix the RCA lesion, kind of protected the left main, supported the left main if we need it. So we simply change diagnosis JR4 to guiding. Then after that, we use BMW pass lesion quite easily by Dr. Najib, and he is dilated with 2O balloon. And after that, we quickly pick up suitable stent size V 2.75 by 28 and deployed. And after that, we do a high pressure inflation using a NC Sprinter, and quite nice results. After while insertion, the patients feels very severe chest pain, so we have to do a quick pre-dilatation initially with the 2O by 20, originally been used for the RC intervention. Then after that, we feel some recoil, and especially the fluoroscope, we can see a calcification in the already osteo and the mid portion. And the patient had been stented for the LAD mid portion using a bare metal stent spec. I don't know what age is how many years ago?
About
8 years ago, before the DS available. So the lesion was just below the original bare metal stent and proximal. Then after that, they have LAD osteo critical stenosis. From IO quarter view, it seems like left main is not that have significant disease, but from the IO cranial view, it's showing that they have some borderline stenosis. So we have to check with IVUS. So after we do additional high pressure inflation using a 2.5 by 15 NC Sprinter, now the patient relative calm down, we can do a IVUS. Hopefully we can have the IVUS information, we can decide where to go and what to do for this patient. So you can watch, I'm moving my IVUS caster quite easily. Now we are passing through the original 3 lesion. Okay, pull back please. Okay, IVUS starts from here. This is already mid portion beyond, quite far beyond that standard portion. So I'm pulling back a little bit. Hopefully patient don't have to tolerate too long procedure. And so we can see here, studies have a lot of plaque. That medial to me is almost like 3. Then original stent here is only about 2.5. But the distal reference I thought should be 2.5 compatible. We are using a 2.5 high pressure up to 20 atmosphere for this tandem lesion. So in between that, the proximal to the stent, we can see a lot of plaque. But good things is because we can see not ring down calcification. Otherwise, we probably have to switch to a rotabrator. So we have a lot of calcification. Patient usually on dialysis easy to have very calcified lesion. But this lady is good. We can see only a 90 degree is calcification. And now this is more severe calcified, but we can see that even calcium line, they have some split by our high pressure inflation 2.5. Okay, so proximal is 3.0 at least compatible. Maybe medial to medius can get up to 3.5 to 4.
So here, Dr. Wu just asked a question about.
Yes.
We mentioned about the cutting balloon.
Yes.
Does that can replace the rotablator?
Back to the counter. Back to the
work,
counter. Cutting, sometimes the ring down calcification, because even the cutting balloons cannot go in, but that's what is the score. So you can see this left main. We can calculate. Maybe Hisham can help me to calculate that distal left main.
Hisham, would like to comment on the calcium score?
Yes, left main is whole. Okay, stop. So what about the minimum luminal area for the distal ligament? You calculate? 5.1. So, yeah, deserve to treat.
So what you're going to do now?
I'm going to dilate the proximal more because I can see the IVUS.
By a bigger back?
Yeah, with a bigger balloon. So after we do additional high pressure inflation using a 3O, we are considering to treat, preparing that proximal already better. 3015 NC Sprinter has been chosen and chosen for high pressure. And the proximal we go 16. Then after that we go very high pressure, 20 and 26 for the LAD osteo and left man. So now we can see that calcium has been spread up, and this is still calcium in the. This is still the standard. Yeah. This. Yeah. Okay. This is still a standard portion. Not yet. Not yet. This is not yet. Because now we can see some 90 degree, but you can see that calcium line is spread. Yeah. 90 degrees calcium is okay. Yeah, 11. But you can see that they have some disrupt of the plaque. Yeah, right. Yes, and 9 o'clock, and here in the 3 o'clock, and 8 o'clock. So it's good things because we can achieve this kind of popping. The stent expansion should be no problem. In the proximal, yeah, near the orifice. But orifice also they have another classification, so we have to see. So the proximal is not that much disease, but have osteostenosis and also calcified. And sooner after this, we can see the wire joining from circumflex. So should be in the 7 o'clock, and this is a distal left main, also quite calcified. We can see some also spread up of the calcium line. So the left main is somewhat not a big, the 3, at least only 3.530, yeah. So my planning is like to put a 2.5 just at distal to the stent, and 2.5. How long we can have? 28 or 33? Okay, Cine? Okay. Cine again. We just make sure that landmark. All right, here. Okay, yeah, up.
Going up, doctor?
Yep, 10,
10 ATM,
12.
12,
Okay, yep, all right.
12 ATM,
12.
12 ATM,
Go to 14.
14, 14 ATM.
Okay, different. So pulling back. Okay, Cine. Okay, we are overlapping. Okay, good. Yeah, here.
So there is
All right, 16. 16.
14, 16 ATM,
Okay, 18.
18 ATM,
All right, perfect. So we do a circumflex IVUS before we do a stenting, showing to the people that not just angio, we have IVUS proof. Okay, the IVUS view now is in the circumflex proximal. As a matter of fact, only a minimal plaque, eccentric. The size of the vessel is 3.0 to 3.5. And because we have decided to cross over to covering the distal ligament lesion and also LAD osteo lesion, so the strategy would be if circumflex no much plaque, we want to do just some plaque, but we'll see. It is near that OM branch. They have some plaque, but it's not to the osteo yet.
Yeah, not
Oh, okay. Just review it. But I cannot see the LED wire, huh? Okay. Yeah, okay, Sini. Yeah, some crack. Yeah, some crack here. Okay, we can just stand and after that we decide. We'd like to just do a crossover. Crossover, then we'll see. Sini, because this is a good view for the exactory ostia. All right, test again. Ask patient don't move. Test. Okay, this is the ostia. Okay, okay, Sini again. We just make sure that we have overlapping and we are covering the ostia.
I think the guiding catheter is inside. I think we should pull the guiding catheter.
Okay, we can. All right, test again. Okay, yeah, this is a good. Okay, up here. Yep. Nice. Okay, it's okay. 10, 12, 14, 16. Okay, done. Okay, check from here. This is all right. Yeah. Okay. Okay, give me back the caudal view. Aerial caudal view. Yeah. We'll check to see the circ. No, you check with the circ. Should be no problem. Usually, this amount of plaque, we are not plaque shifting too much. Yeah, we have some narrowing. So go back to the original spider view, and we can rewiring. Give me another wire, and prepare the 3O high pressure. We can 3O high pressure. We can do like anchoring in case we don't. Yeah, we cannot cross. 3O. So we have two indifferenter. One is 3O high pressure, and one is 2O.
Plan now is to
We can do open the centrot to the circumflex.
Okay.
Then what's the size of the circ by the IVUS is 2.5, 3.1. But might be, if it's possible, we have 2.5 high pressure balloons. No, we have on the table. So after the pre-dilatation, dilate the centrot with 2.0, we can use a 3.0 and 2.5. Try to maximize the bifurcation carina area.
simultaneous kissing
The
dilatation.
balloon dilatation.
And so
3.0 only, yeah. Okay, so simultaneous, we go 16 and 16 and 16. Okay, go.
How many ATM?
16, both.
14, 16, 18.
Okay, done. All right. Yeah. So I'm keeping this. Prepare the 2.5 high pressure. So like a crash nowadays.
Which technique you think will give you a better LCX os result?
I thought different techniques should be the same. Okay. Yeah, we can do angio. Okay. All right. All right. Angio. Yeah. Yeah. Okay. See. Inject more. All right. Some plaque, but he's okay. Okay, we go circ. So it's recorded from circumflex the proximal portion. After we do a kissing balloon inflation 3.0 high pressure for the laminarity and 2.5, 15 high pressure again for the circumflex ostia. The initial plaque shifting looks to me angio is better, but we have to take the IVUS to see if there any dissection created by this balloon dilatation or not. Basically, will be, I would say, just keeping the same the lumen size. Previous measuring after stenting, they have 4 point something. Before stenting, 4.7. So because we are not too aggressive dilate the circumflex ostia, so I probably would keep it. And we are actually good. The lane is just proximal to the lemon orifice.
so what's the plan now?
Yes, just IVUS, the RAD. Then probably I would, if you allow me, I would stop here. According to the IVIS, we calculate and dilated the lesion 2.5 for the distal and 3.0 for the proximal, and the first stent 2.5 by 38 promus elements. This is the longest stent we have here. And deployment at about 10, 12. Then we pull back, get up at 16. Then overlapping according to the stent balloons, measuring 3.0 by 38, overlapping with 2.5. The proximal age was just before the arete osteo. Then after that, we do the third stent, 3.5 by 23, because showed it's 24 for promus element. So we pick up a Zion's V, 3.5 by 23 for the left main arete. And see two layer now because it's previous bare metal stent in-stent restenosis, and this is the gap between the two bare metal stents. Should be in the diagonal takeoff site, and after that we can see additional bare metal stent outside of this newly deployed stent. Okay, this is two layer now. So the proximal portion I'm quite happy because you can see that we use 3.0 high pressure, push up to 20, then 24, 26. Finally, we didn't use a 3.5 high pressure. We are using a 3.0 and the 2.5 for left main bifurcation, kissing balloon inflation. We got up at 16 for both. Okay, I'm happy with this one. This is a proximal RT. All right. Yeah, very good expansion. Very good, deployment. Yeah. Okay, this is a bifurcation. Looks to me is okay. I feel it's okay, and because it's kissing balloon inflation, the left main is become overshaped. But the minimal stent area should be large enough, and we are covering to the orifice. Okay, yeah, this is outer osteo of the left main. All right, Sini. Okay. All right, perfect. Okay.
Take another spider.
Yeah, spider. Yeah. And how about the left main? You calculate the minimal stent. Okay. All right. Testing. Okay. Okay. All right. All right. Oh, push harder. Push harder. All right. Yeah, I think it's acceptable. Yeah. Okay. Cross here.